Our next speaker will be Dr. Neil Patel. He's a consultant neonatologist, Royal Hospital for Children, Glasgow, UK. He's a lead for neonatal hemodynamics and has a leading role in the care of newborn with congenital diaphragmatic hernia. He will talk to us about the pulmonary hypertension phenotypes, how to assess and manage.
Hi, thank you very much for the kind invitation to join you. It's an honor to be here today. I'm going to be talking about persistent pulmonary hypertension phenotypes and our clinical approach to assessing and managing these. Many of you will be experienced and familiar with a patient with the clinical picture of PPHN, a patient who is hypoxic and cyanosed, who is acidotic with a combination of respiratory and metabolic acidosis, and who has systemic hypotension, and who appears to be in a worsening spiral. And the challenge for us is to try and break that vicious cycle or spiral, and hopefully to improve outcomes for these patients. And what I'd like to talk about today is, first of all, the pathophysiology of this clinical condition that we call PPHN, but which actually has a number of different and varied mechanisms. I'd like to then talk about our approach to the clinical assessment of these patients and the systematic way in which we can try and identify their underlying hemodynamic phenotype, and then use that to discuss a more targeted precision medicine approach to management, including the appropriate use of pulmonary vasodilators, inotropes, and vasopressors in these patients. Let's think first about the pathophysiology of pulmonary hypertension of the newborn. By pulmonary hypertension, we mean elevated pulmonary artery pressure. And pressure, of course, is the product of pulmonary vascular resistance and pulmonary blood flow. The pulmonary vascular resistance is determined by the net resistance of the pulmonary circulation, as well as a contribution from blood viscosity. And the resistance of the pulmonary circulation in a normal circumstance is predominantly determined by the precapillary elements, in particular, the tone of the pulmonary arterioles. And that has both a structural component associated with the size and number of the pulmonary arterioles, but also a functional element related to the tone of the pulmonary artery smooth muscle. There's also a contribution to pulmonary vascular resistance that is postcapillary, determined by the pulmonary venous pressure, and in turn, the pressures in the left atrium and the left ventricle. And under normal circumstances, that's a relatively minor contribution, but it may become important in disease states, and we'll talk about that later. If we want to understand the mechanisms of pulmonary hypertension of the newborn, then we need to appreciate the importance of the normal transitional process from the fetus to the ex utero environment. And that's represented schematically here. In the fetus on the left-hand side, of course, pulmonary vascular resistance is high, pulmonary blood flow is low, and the majority of right ventricular output passes across the ductus to support the systemic circulation. Of course, at birth, there's a major change in the circulation. The combination of aeration of the lungs, of ventilation, combined with oxygenation of the alveoli, leads to an acute drop in pulmonary vascular resistance, and that will promote increased pulmonary blood flow. The right ventricle takes on the role of delivering that pulmonary blood flow, and the increase in pulmonary venous flow leads to increase in left ventricular output as the left ventricle takes on the role of supporting the systemic circulation. But it's disruption of that normal process, both at the level of the pulmonary vasculature, but also at the level of the heart, which contributes to the clinical picture of PPHN that we can see. All babies are born with elevated pulmonary artery pressure. It takes some time for it to come down, but not all babies have that clinical picture of PPHN. The ones who have that pathophysiological picture are the ones in which there's persistence of pulmonary artery pressure, giving rise to downstream pathophysiological effects. And one of those effects, as we all know, is right to left shunting across the atria and the PDA in postnatal life, giving rise to the hypoxic component of PPHN. But the other downstream effect of ongoing persistent elevation of pulmonary artery pressure is the effect that it has on the heart. And that starts with the effect on the right heart. If the right ventricular afterload is persistently elevated after birth, then that will lead to adaptive and ultimately maladaptive responses in the right ventricle. And you can see that here in this 4-chamber echocardiographic loop on the left-hand side. The right ventricle is dilated. It's got this almost squared off appearance. It's hypertrophied with thickened myocardial walls. And there's displacement of the septum, which is reducing the left ventricular volume. And you can see that represented schematically in the top right-hand picture. The thin-walled right, normally thin-walled crescenteric right ventricle in cross-section becomes this thick-walled concentric structure. What's happening here is the right ventricle is initially hypertrophying to try and generate increased pressure to overcome the increased afterload or pulmonary artery pressure. But as that fails to achieve the required increase in right ventricular performance, the ventricle also dilates and becomes tachycardic to try and maintain stroke volume and right ventricular output. But ultimately, the right ventricle becomes uncoupled from the pulmonary circulation and starts to fail. And in particular, it starts to show diastolic dysfunction as well as systolic dysfunction. And that failure of the right ventricle in the setting of pulmonary hypertension will lead to reduced pulmonary blood flow and exacerbate hypoxemia in these patients. But it's not just the right ventricle that's affected. The right ventricle and the left ventricle are inseparable. They have shared muscle fibers, as you see in this tensor MR imaging on the left-hand side, that wrap around both ventricles and across the septum. And therefore, dysfunction in the right ventricle will intrinsically affect function in the left ventricle. In addition, because of their shared septum and shared pericardial space, those changes in right ventricular size and morphology impact on left ventricular shape. And as you saw in the echocardiographic image in the previous slide, they will reduce left ventricular size and therefore left ventricular filling. And the combination of these effects leads to impaired left ventricular performance and impaired left ventricular output. And the combination of hypoxic right to left shunting with impaired right and left ventricular performance in pulmonary hypertension gives rise to impaired systemic blood flow, impaired systemic oxygen delivery, and the clinical picture that we described already: hypoxia, metabolic acidosis, and systemic hypotension. We'll also see respiratory acidosis because of reduced pulmonary blood flow and therefore impaired CO2 clearance. A really important consideration, however, is that left ventricular dysfunction itself, whether primary or secondary, may also contribute to increased pulmonary artery pressure and the clinical picture of PPHN. And that's because if there's left ventricular dysfunction and increased left ventricular diastolic and left atrial pressures, that will in turn lead to increased pulmonary venous pressure and the post-capillary increase in pulmonary artery pressure. And that may be really important when we think about how we treat these patients. And we'll use some cases to illustrate that later on. So to summarize, when we think about the hemodynamics in pulmonary hypertension and in that clinical picture of PPHN, there may actually be quite different cardiovascular phenotypes. The normal situation is represented on the left-hand picture, what we might call coupled circulation. The right ventricle is coupled to the pulmonary circulation, the left to the systemic circulation. The second panel from the left represents what we might call a pulmonary arterial or precapillary phenotype, where we see that right ventricular dilatation and dysfunction giving rise to secondary left ventricular compression and dysfunction. And characteristically, we'll see a right to left shunt at atrial level in these patients. The third panel represents one of primary left ventricular dysfunction, giving rise to increased left atrial and pulmonary venous pressure. We might call that a pulmonary venous or post-capillary phenotype. In this situation, the atrial shunt may actually be left to right. And then the final diagram on the right-hand side represents a composite situation where we see biventricular dysfunction with dilatation and dysfunction in the right and dysfunction in the left ventricle, giving rise to a combination of pre and post-capillary increases in pulmonary vascular resistance. And it's important that in individual patients, we understand which phenotype is present because it will affect our therapeutic choice. So at the bedside, how are we going to identify those individual phenotypes? Well, I would say that it's important that as part of our routine clinical assessment in these patients, we serially assess their pulmonary artery pressure and their oxygenation and those relative contributions of right and left ventricular function. And we have a number of established techniques and measures that allow us to do that. You'll all be familiar with the use of pre and post-ductal saturations to assess, pulmonary artery pressure. And we combine that with echocardiographic assessment or estimation of pulmonary artery pressure, including use of patent ductus arteriosus flow, tricuspid regurgitation, and other measures, including pulmonary artery acceleration time and septal position, which we can quantify using eccentricity index. We assess oxygenation by looking at oxygen saturations and partial pressure of oxygen, as well as measures of systemic oxygen delivery, including near-infrared spectroscopy, systemic venous oxygen saturations, and plasma lactate. And functional echocardiography is key to help us assess right and left ventricular function, both qualitatively by eyeballing the ventricles on 2D images, but also using quantitative measures that are based on time intervals, on displacement of ventricular structures, and on deformation imaging, which allows us to look at changes in myocardial velocities and relative displacement of regions of the myocardium that we call ventricular strain. And I'm going to show you some examples of those. So what I'd like to do for the remainder of the talk is use 3 cases to illustrate the different PPHN phenotypes, how we assess them, and a different approach to managing them. First one is a patient born at 41 weeks gestation, emergency cesarean section with thick meconium. Patient has hypoxia, is hypercarbic, and is hypotensive. So meets our definition of PPHN or hypoxic respiratory failure. But what's the mechanism here? And how can we understand the phenotype? First of all, let's make some assessment of the pulmonary artery pressures. In the top left-hand panel, you see an apical 4-chamber view. The right ventricle is dilated, and the blue jet represents tricuspid regurgitation. When we measure the velocity of that, we can see that it's significantly elevated and allows us to estimate right ventricular systolic pressure. On the right-hand panel, top right-hand panel, you can see the patent ductus arteriosus, and a Doppler waveform of that in the panel below show that it's predominantly right to left shunting in the ductus. So combined with a tricuspid regurgitation velocity, both of these confirm for us that this patient has significantly elevated pulmonary artery pressure. Now, in the setting of this patient who had fetal distress, thick meconium at birth, the mechanism of increased pulmonary vascular resistance that we're all familiar with is almost certainly one of a functional failure of normal pulmonary vasodilatation at birth. And this is what I consider to be true PPHN, this failure of the normal transition, normal drop in pulmonary vascular resistance due to failure of vasodilatation in a otherwise normal pulmonary arteriole. And there are a number of conditions which give rise to this failure of the normal functional pulmonary vasodilatation at birth, of which you'll be familiar, and meconium aspiration is one potential contributing factor. What about the ventricular function phenotype in this patient? Well, we can assess that using a number of echocardiographic quantitative techniques. One of these is TAPSE, or tricuspid annular plane systolic excursion, which you see here represented schematically on the right. And it looks at the relative displacement of the tricuspid annulus during systole, which in this case is reduced, indicating reduced right ventricular systolic function. Another technique which we've used to show that in babies with PPHN, including in this particular case, is tissue Doppler imaging, which allows us to look at the relative myocardial velocities in the ventricle, and in particular in the right ventricle and the septum. And what you see in the middle panel is a waveform from a control infant compared to this case in the right-hand panel. And what you can see is a reduction in what the systolic tissue Doppler velocity, or S prime, but also very strikingly, a reduction in the E prime or early diastolic velocity, indicating impaired diastolic dysfunction in this right ventricle. So this patient has a picture of elevated pulmonary artery pressure with right ventricular dysfunction. So this is what we might call a precapillary or right ventricular dysfunction phenotype, where, as represented in the diagram on the right-hand side, the predominant finding is one of right ventricular dilatation and dysfunction with secondary left ventricular compression and dysfunction. And the therapeutic approach in this phenotype should naturally be one of reducing the right ventricular afterload to try and improve pulmonary blood flow and improve right ventricular function. So it makes sense in this setting to use pulmonary vasodilators, including nitric oxide or sildenafil in intravenous or oral form, to try and reduce the pulmonary vascular resistance and support right ventricular function. One of the other agents we use in this setting is milrinone, which is both a pulmonary vasodilator as well as a positive inotrope and a positive lusitrope, by which I mean it supports diastolic function. In this setting, we also tend to use prostaglandin E1 if the patent ductus is closing to try and maintain the ductus as a blow-off valve for the right ventricle. And by doing so, we aim to reduce the effective afterload in the right ventricle. In this setting, it almost also makes sense to try and maintain a normal systemic blood pressure to try and support coronary blood flow to the right ventricle. And there's a case here for gentle vasoconstriction, perhaps using low-dose norepinephrine or vasopressin. That's important to recognize that it may not be appropriate in other phenotypes, however, and we'll come on to that. So let's look at a different situation of pulmonary hypertension in a newborn. In this case, an infant with left-sided congenital diaphragmatic hernia. This was diagnosed antenatally, and on fetal assessment, the patient had a lung-head ratio, so an assessment of fetal lung volume, which was 28%, putting them in the moderately severe category. At 12 hours of age, the patient is hypoxic, they're hypotensive, and they're acidotic. So they have effectively hypoxic respiratory failure and our clinical picture of PPHN. But what's the underlying mechanism? Well, again, let's look at what the functional echocardiography can tell us. Here is a view of the patent ductus, which is widely open, and the Doppler shows that the ductal shunt is predominantly right to left, indicating pulmonary artery pressures that are close to or above systemic pressures. So we've definitely got evidence of elevated pulmonary artery pressure. And traditionally in CDH, we attribute that increased pulmonary hypertension to a precapillary increase in pulmonary vascular resistance that we believe is due to both a functional and structural change in the pulmonary vasculature and the pulmonary arterioles. And you can see that in the histological specimens in the bottom right here. Here's a pulmonary arteriole from a CDH patient compared to control. And you can see that there's a marked thickening of the pulmonary arterial wall here. The adventitia and the muscular layer are increased, leading to a much narrower vessel, which gives rise to the increased resistance in these patients. So we believe that, as I mentioned, that there's a precapillary increase, which has both a structural and a functional component in these patients. However, that's not the whole story in this patient. Here's an apical four-chamber view of this patient with CDH taken in the first hours of life. And what you can see is subjectively a degree of dysfunction in the right ventricular free wall, perhaps slightly better function in the septum. But look at the left ventricular free wall. It's not moving normally, certainly not as well as the septum. And this is something that we've tried to objectively look at using quantitative techniques in patients with CDH in the first hours of life. And one of the techniques that we've used is Speckle tracking echocardiography. This allows us to look at the relative shortening of regions of the myocardium in the left ventricle during systole, and to generate these strain curves. Strain is the relative shortening in systole. And from these, we can calculate a global strain in the left ventricle. And in this patient, it was reduced, -9%, indicating systolic dysfunction in the left ventricle. And in a cohort of patients with CDH, we've shown that a number of them will have impaired systolic function that is disproportionate to the degree of dysfunction in their right ventricles. And in these patients, we believe that the left ventricular dysfunction, giving rise to increased pulmonary venous pressure and a post-capillary increase in pulmonary vascular resistance, is a significant contribution to the pulmonary hypertension in these patients. So it's not just due to the precapillary changes in the pulmonary vasculature, it's the left ventricular dysfunction that is a primary cause of pulmonary hypertension. And in these patients, therefore, we believe they have this left ventricular or pulmonary venous phenotype of pulmonary hypertension, contributing to the pathophysiology of the clinical picture of pulmonary hypertension in these patients. And we've shown in a cohort of patients with CDH, analysed in the CDH study group, which collects data from over 60 centres internationally, the important relationship between left ventricular dysfunction and outcome. This is data from over 1,000 CDH patients who were characterised according to their cardiac function in the first 24 hours of life. And this Kaplan-Meier plot shows their survival over the first 100 days. And what you can see is that survival was greatest in those patients that had normal function, but progressively deteriorated in patients who had right ventricular dysfunction, left ventricular dysfunction, and in the most severe category, patients who had combined right and left ventricular dysfunction. And this data was really important in showing us that left ventricular dysfunction is an independent predictor of mortality in CDH. And with that knowledge, in those patients that have this left ventricular phenotype, we need to have a different approach to management. In this case, we need to support left ventricular function in those first hours and days of life by using gentle inotropy and avoiding excessive vasoconstriction and afterload in the left ventricle. And we like to do that using low-dose epinephrine combined with milrinone. We want to avoid using pulmonary vasodilators in these patients, because the theory is that by doing so, we may increase filling of a failing left ventricle and may, in fact, worsen left ventricular dysfunction. But there is a case for continuing to maintain the patent ductus in these patients to support systemic blood flow and augment the left ventricular output. And as I mentioned, we want to avoid using pulmonary vasodilators. And the analogy here is of a blocked toilet. If the left ventricle is the toilet and it's failing to empty, then the theory is that if we give pulmonary vasodilators, we'll just continue to fill that blocked toilet. What we need to do is unblock the toilet by giving inotropes and supporting left ventricular function. And the important thing to appreciate is that left ventricular function itself is a transitional phenomenon, and the dysfunction will improve itself over the first few days of life. Let's move on to the third case. A term infant, respiratory distress from birth, hypotensive, hypoxic, and acidotic. So they fit our clinical picture of PPHN hypoxic respiratory failure. On echocardiogram, they also have a predominantly right to left shunt in their PDA and an increased tricuspid regurgitation jet velocity, as you see on the right panel, indicating elevated pulmonary artery pressure. On this apical four-chamber view on the left-hand side and the short axis view through the ventricles on the left, you can see that the right ventricle is very dilated, as is the right atrium. The left ventricle is compressed, and there's dysfunction in the right ventricle and the septum. But another unusual finding in this patient was retrograde flow in the aortic arch. And you can see that on the color Doppler on the left-hand side and on the Doppler signal from the transverse arch on the right-hand side. And you can also see that the head and neck vessels are very dilated in this patient. And one other abnormal finding in this patient was not a low right ventricular output, but actually a very high right ventricular output. And this patient actually turned out to have a large intracranial arteriovenous malformation, what we call a vein of Galen malformation. And high flow through this AVM leads to high output cardiac failure and increased pulmonary blood flow. So the mechanism of pulmonary hypertension in this patient is not increased pulmonary vascular resistance, but is actually increased pulmonary blood flow. And we can see that in this schematic representation of a patient with VGAM compared to a normal heart on the left-hand side, where we were able to measure blood flows in different regions of the heart and major vessels. And what you see is a disproportionately high blood flow through the right ventricle and up to the head and neck, returning in the SVC. And in these patients, our therapeutic approach is one initially of systemic vasodilatation to try and optimize systemic blood flow and prevent multi-organ failure, but ultimately to embolize the intracranial AVM and reduce the shunt through it. So I've shown you 3 cases, all of which presented with the clinical features of PPHN, but they highlight to you that PPHN is not a single diagnosis, it's a clinical description. And we need to use our clinical assessment, incorporating functional echocardiography in individual patients to understand their individual pathophysiological phenotype. And by doing so, we can then have a targeted precision medicine approach to individual phenotypes. And a really important distinction to take home is this one between right ventricular phenotypes and left ventricular dysfunction phenotypes, and the different approaches to management here. In those with a right ventricular dysfunction phenotype, our approach should be aggressive reductions in pulmonary vascular resistance, including the use of pulmonary vasodilators. These are likely to be the group who may benefit from these drugs. However, in those patients with a left ventricular dysfunction phenotype, our aim is to support the left ventricle, allow it time to recover, and to be very cautious about the use of pulmonary vasodilators, which may theoretically worsen the situation. So thank you very much for listening. I hope that that's been an interesting discussion for you, and I look forward to your comments. If you'd like to get in touch, my email is here, and I'd like to thank everybody who's been involved in our work. Thank you very much.
Can we connect Yasser, please? Dr. Yasser Said, please, with us.